Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article.
Welcome to SummaryCast. Today we're looking at a feature in head and neck cancer imaging that's both critically important and notoriously difficult to assess with confidence: extranodal extension.
Right. This is when a tumor inside a lymph node breaks through the node's outer wall or capsule and starts invading the surrounding tissue. It's a sign of more aggressive disease.
Exactly. It signifies a biological shift in the tumor's behavior. It's no longer contained, it's actively infiltrating. And being able to spot this on a CT or MRI scan before treatment even begins has major implications for a patient's prognosis and therapy.
A new review paper tackles this very challenge.
It is. It's titled Imaging Detected Extranodal Extension in Head and Neck Cancer: Current Evidence, Standardized Grading, and Clinical Implications. It was published in the April 2026 issue of the Korean Journal of Radiology.
So it's a comprehensive look at where the field stands today.
Precisely. It synthesizes the evidence, outlines the persistent problems, and details the latest efforts to solve them. Let's start with the traditional approach.
Okay, this was originally a pathological diagnosis, correct? A surgeon removes the lymph node. A pathologist slices it, looks under a microscope, and makes the call. They call it PENE, for pathological extranodal extension.
That's the gold standard. But here's the fundamental clinical dilemma. A huge number of patients with head and neck cancer, especially those with cancers related to HPV or those in the nasopharynx, are treated with primary chemoradiotherapy. There's no upfront surgery, so there's no surgical specimen.
Which means for that entire population, the only chance to detect this aggressive feature is on the initial diagnostic scans.
Right, that's imaging-detected iENE, or iENE. It's the only way to get that crucial prognostic information before treatment begins. And the evidence is mounting that this information is powerful.
How powerful? The paper summarizes several meta-analyses. How well does iENE actually correlate with patient outcomes?
Very well. The paper's Table 1 consolidates the findings. It shows that iENE is an independent predictor of worse outcomes in both nasopharyngeal carcinoma, or NPC, and HPV-positive oropharyngeal cancer.
Worse outcomes in what sense?
Both overall survival and distant metastases-free survival. For instance, in HPV-positive oropharyngeal cancer, one meta-analysis showed that patients with iENE had a hazard ratio of 2.64 for overall survival.
Let's unpack that. A hazard ratio of 2.64 means that at any given time point, a patient with iENE has over 2.5 times the risk of death compared with a patient without it. That's a huge difference.
It's a massive signal. And here's a really subtle but important point the paper makes. iENE can actually be a stronger prognostic factor than PENE, the pathological finding.
Wait, that seems counterintuitive. How can an imaging finding be more predictive than the supposed gold standard from pathology?
The paper offers a compelling theory. Pathological ENE can range from a tiny, microscopic breach of the capsule to massive, gross invasion. What's visible to the naked eye on an MRI or CT scan, frank invasion into fat or muscle, likely represents the more extensive, aggressive end of that spectrum.
So iENE is essentially selecting for major ENE, which carries the worst prognosis, while PENE lumps both minor and major ENE together.
That's the thinking, and this growing body of evidence has triggered real change in clinical practice.
This is where staging comes in.
Exactly. The American Joint Committee on Cancer, the AJCC, has taken note. In its latest 9th edition staging system, which started in 2025, Advanced Radiological ENE is now officially an N3 staging criterion for nasopharyngeal carcinoma.
So it's gone from just a descriptive finding in a radiology report to a formal determinant of a patient's stage. That raises the stakes for radiologists considerably.
It absolutely does, which brings us to the central problem the paper addresses. If ENE is going to be used for staging, how well can it actually be identified on scans?
And the paper's answer is?
In a word, moderate. The diagnostic accuracy of both CT and MRI is far from perfect.
What are radiologists even looking for? What are the classic signs?
The paper lists the common features. Things like irregularity of the node's capsule, infiltration or stranding in the fat around the node, the loss of clear fat planes between adjacent nodes, and of course, direct invasion of structures like muscle or blood vessels.
A lot of those sound subjective. Irregularity or infiltration can be in the eye of the beholder, especially if there's inflammation.
And that's the core of the problem. The numbers bear this out. The paper pulls data from 4 different meta-analyses in its Table 2. For CT, the pooled sensitivities range from 63% to 77%, with specificities from 77% to 85%.
And MRI?
MRI is in a similar ballpark. One large 2024 meta-analysis by Mayer and colleagues suggests MRI has a significant edge in sensitivity, 83%, compared to 63% for CT in their analysis. But specificity was the same for both, at 85%.
So MRI might be better at picking it up, probably due to better soft tissue contrast, but neither modality is perfect. And the real issue, as you mentioned, is consistency. The paper uses the phrase substantial inter-observer variability.
Precisely, even among fellowship-trained head and neck radiologists. A 2023 study cited in the review tested reproducibility for various imaging signs of iENE. It was sobering. Features like irregular nodal margins had a Fleiss kappa of just 0.21.
Yikes! For context, a kappa of 1.0 is perfect agreement, and 0 is what you'd get by chance. A value of 0.21 is considered slight agreement. It's not much better than flipping a coin.
It's a serious problem. If 2 experts can look at the same scan and disagree on a feature that now influences the patient's formal stage, the system breaks down. This chaos was the main driver behind the biggest development discussed in this review, a major international effort to standardize the diagnostic criteria.
This sounds desperately needed. Who was behind this effort?
It started with the Head and Neck Cancer International Group, or HNCIG, which developed initial consensus criteria. Publication of their system then prompted the 3 major regional societies, the Asian Oceanic, American, and European Societies of Head and Neck Radiology, to form a joint task force to refine and promote it.
And what did this international collaboration produce?
A 4-tier classification system for assessing iENE, which is detailed in the paper's Table 3. The goal is to create a common language and a consistent set of rules for radiologists everywhere.
Okay, let's walk through it. It's a grading system from 0 to 3.
Correct. Grade 0 is simple. Absence of definite iENE. The node looks clean with sharp, well-defined margins. You can see this in images A, B, and C of Figure 1 in the paper.
Simple enough. What's grade 1?
Grade 1 is defined as perinodal fat invasion, but here is where the standardization really kicks in. They get very specific about what this means. It's no longer just a slightly fuzzy or ill-defined border.
What's the new stricter threshold?
To call grade 1, you need to see clear, unequivocal projections or spikes from the node's surface extending into the surrounding fat. An ill-defined margin by itself is no longer sufficient. This is a crucial change in practice designed to reduce subjective calls.
So they're raising the evidentiary bar to make a positive call, trying to cut down on false positives. What about grade 2?
Grade 2 is for matted nodes. This is when 2 or more metastatic nodes appear to have fused into a single conglomerate mass.
This is another term that can be subjective. How did they standardize that?
By requiring 3 specific criteria to be met simultaneously at the point of contact. First, the loss of the fat plane between the nodes. Second, the loss of the normal outward curve or convexity of each node. And third, the loss of the sharp acute angles between the nodes.
So all 3 have to be present. This ensures you're looking at true nodal coalescence, not just 2 nodes that happen to be touching.
Precisely. It's a much more rigorous definition. And finally, grade 3 is the most overt form.
Invasion of nearby structures.
You got it. Grade 3 is defined as clear, unambiguous extension into adjacent organs like muscle, skin, glands, or the neurovascular bundle. The paper's Figure 1 has some great examples, showing a nodal mass replacing the sternocleidomastoid muscle and even a tumor thrombus inside the internal jugular vein.
A key theme here seems to be the word unequivocal.
That's the guiding principle of the whole system. The paper emphasizes that the task force explicitly states that if a feature is ambiguous or equivocal, it should be considered absent for the purposes of grading.
That's a critical point. The risk of overcalling iENE is significant. You could potentially prevent a patient from getting curative surgery or steer them toward unnecessarily toxic treatment.
Right. But it's important to note, as the paper does, that this system is based on expert consensus, not yet on large-scale outcome-based validation. Its correlation with patient outcomes still needs to be proven.
So it's a tool to standardize reporting and research for now. Its direct impact on clinical decision-making is still being established.
That's a perfect summary of its current status. It's a framework for communication and consistency, which is the first step. With all this talk of variability and the need for unequivocal signs, it seems like a prime area for artificial intelligence to play a role.
The paper has a section on this.
It does, and the initial findings are pretty compelling. The authors reference a systematic review and meta-analysis of studies using machine learning algorithms to detect iENE on CT scans. The results were stark.
Let's hear the numbers.
The machine learning models achieved pooled areas under the curve, or AUCs, of 0.91 to 0.92. For comparison, the pooled AUC for radiologists in the same analysis was 0.65.
Wow, that is a massive difference in diagnostic performance. An AUC of 0.65 is considered poor, not much better than chance, while an AUC over 0.90 is considered excellent.
It's a huge gap. It suggests the AI models are picking up on subtle patterns, perhaps related to texture or density heterogeneity, that are predictive of iENE but are difficult for the human eye to consistently appreciate.
So what's the catch? If the models are that much better, why aren't they in use everywhere?
It's the usual litany of caveats for AI research at this stage. Most of the studies are small, retrospective, and from single institutions. They use different imaging protocols, different model architectures, and different reference standards for iENE.
So external validation and generalizability are the big unanswered questions. A model trained at one hospital on one type of scanner might fail completely at another.
Exactly. But the potential is clearly there. The review highlights one particularly fascinating study from 2026 by Dine and colleagues that pushes the idea even further.
What did they find?
They developed an AI model to predict iENE in HPV-positive oropharyngeal cancer. Not only did the model perform well, but its prediction of iENE status turned out to be a stronger prognostic biomarker for survival and metastasis than the human radiologist's iENE assessment.
Hold on. Let me make sure I understand that. The AI's classification of the lymph node was more predictive of the patient's actual clinical outcome than the expert human's classification?
That's what the study suggests. It hints at a paradigm shift. It's not just about the AI being better at performing the human task. It might be performing a slightly different, more clinically relevant task altogether.
It could be identifying a unique, prognostically relevant imaging phenotype that doesn't perfectly align with our traditional visual criteria. That's a powerful concept.
It's a very thought-provoking idea. But again, it's a single institution study that needs extensive validation before anyone can act on it.
So if we pull all of this together, what's the final take-home message from this review for a practicing radiologist?
The paper positions iENE as a critically important but still evolving imaging biomarker. Its prognostic significance is now undeniable, and it's cemented in formal staging systems, which raises the bar for every report.
And to meet that bar, the field has produced this new, more rigorous 4-tier classification system. The goal is to standardize the language and reduce the dangerous variability we've had until now.
Right, it provides much-needed guidance. However, the authors are clear that these recommendations should be seen as contextual and adjunctive, rather than definitive criteria for making clinical decisions on their own, at least for now.
Because the correlation with pathology is still imperfect, and the system itself, while logical, hasn't been validated against patient outcomes yet.
Exactly. So for today, the advice is to adopt the standardized grading system, be extremely rigorous about applying the unequivocal rule to avoid overcalling, and be transparent about the limitations of current imaging tools in multidisciplinary discussions.
And keep a very close eye on AI, which looks poised to make a big impact here once the models are properly validated in larger, more diverse populations.
I think that captures it perfectly. The goal is a stepwise progression. First, standardize human interpretation to create a reliable baseline. Then, prospectively validate that system. And finally, integrate validated AI tools to augment and potentially even surpass human performance.
A clear summary of a complex and important topic. That concludes this episode of SummaryCast.
Thank you for joining us.